So I will request Dr. Subhadra Jalali to please come and deliver your address.
मैडम का इसमें क्या? मैडम इसमें मैडम इसमें है? अच्छा ठीक। सॉरी आपको
I'll be very brief. All my work is with the babies, as you're aware. And I'm just going to tell, whenever we treat these patients, the first and the only question parents have is that, will my child go to school? You're doing all this treatment, what will happen? So we are telling them, just wait. School is still 5 years away. Okay, before that, child has to achieve a lot of milestones. So that is the difference between treating babies versus treating any other group, toddlers, because they not only have to develop the vision, but there are so many other challenges which are there. You can see here the child is very small, tiny, so even its health problems are being taken care of. And in that, this is the neurodevelopmental period. So it's not only the vision which has to develop, but everything else. And they have so many other issues like hearing loss, dyslexia, ADHD, epilepsy, cognition defects, motor defects. So if the patient cannot sit, how is he going to look at the low vision thing? So patient may not sit for months, years, he may not even turn around. So how do you, address their low vision or their poor vision? So these are some of the challenges which happen, but yes, there are ways. So you can see here on the day 1 of surgery, I'm trying to see whether the child is looking at my hand or not, and the child is looking, this stage 5 child who was not even looking at light before surgery. So this is on day 1. So our aim when we operate these children, whether it is congenital cataract or any of the pediatric cases, newborns, we must have that in mind that we have to improve their vision and their neurodevelopment. It's not just giving a good IOL or controlling the pressure. So if we look at the visual acuity outcomes, for example, in the cryopy study, this is at 5.5 years they reported. Before that, they didn't report any visual function. They reported only the teler acuity at 3 years and then the visual outcomes. And you can see it's not very good. Hardly 13% patients got 20/40 or better vision. But in a disease where the retina is attached, why should this happen? We can improve these outcomes, and I had written a letter to editor when they published the ETROP that we can have better outcomes if we also address their visual function, their refraction, vision right from day 1, not wait for things to happen on their own. So that is in my clinic, the day patient comes for evaluation, even pre-operatively, we send them to our rehab. There's a whole session there where the parents learn what is the current vision, how to evaluate, what we have to do post-op, because post-op patients are busy with leaving the station, they want to go back home fast, the child is not opening eyes for a few days, there's redness, watering, there's eye shield, there are eye drops, then you can't give them that training there. So if we can give them pre-op, they have a very good idea that as soon as my child is comfortable, I can start the plan. So the post-treatment visual management, if you have a retina like this, you may think that, okay, this child will see everything, but there is so much scarred retina, what will this child see? With proper care, you can see that at 5 years, his handwriting is better than mine. All this is possible by proper management right from day 1. Not wait for them that they have to go to school and then start working on this. Okay, so we have this program where we
Madam,
start
please
them.
try to sum
Yes,
up.
yes, this is the last slide.
Acute
We
shortage of
start
time.
before surgery, then at 1 month, then at 4 to 6 months, we do a lot of teleconsult, WhatsApp videos of what the child is seeing, and that's very important for these babies. So even babies who are handicapped, you can have this what we call as Be Active box. We now also have a pediatric baby vision that you can see in the LVPI stall where we have installed it. And you can actually give them this low vision stimulation, monitor their vision objectively, subjectively, and of course there's no shortcut to the refractions. You can see here, their refractions are mostly myopic, but if they're aphakic, it's not stable. They will have very poor vision to begin with because retina is detached. It attaches only in 2 years. So you have to change their refractions in a different way. So that's what I wanted to highlight, that these children, they can be trained, treated in different ways for their low vision right from childhood, not wait for them to go later in life. And there are various stimulating environments that are made for different types of children, and their vision can be improved, and it can be monitored also, and it can be recorded also. So the approach should be of positivity, as sir said. that they are very depressed patients. They have to be understood that it's a long journey, it's not going to be a short journey, and they have to start with some simple things, and the patient will respond. So don't keep on asking, will my child go to school, will it study? You can do so many things before that. So even in the toddlers, don't ignore their visual acuity and their journey. Most of them can respond very well to colors. So our Dr. Ramesha has done brain and eye study in children who had cataract surgery done later in life, and they found that color vision is something they never lose. Motion is something they never lose. So movement, slow movements and colors, those are the first steps to rehabilitating the children.